So, cher chairman, Professor Benziad et Professor Hayad, the second talk is about the management of kidney allograft rejection. And so, a few things. Tomorrow morning, you will have a lecture at the first atelier by Dr. Mehdi Mendimerad about the Banff classification. Oh, ça, je suis bloqué là. Okay, so first of all, we have this patient, a male patient, never transfused, never transplanted. So in this case, you don't need to have an immunological workup. Why is that? Because he has no sensitization against HLA antigens. And so if you were to use the Luminex screening test for HLA antibodies, it's positive, it's a false positive. Okay, don't forget that. So when the patient has been transfused in the past, or the patient has been previously transplanted, or if it's a woman with miscarriages or pregnancies, she might be sensitized. It might be sensitized even though there is no longer detectable anti-HLA antibodies, because there is the memory B cells, the plasma memory cells also. Okay, so this is the intermediate risk. And the high-risk patients are those with circulating anti-HLA antibodies, donor-specific antibodies, and in these cases, kidney transplantation can be attempted, but the likelihood of having a rebound post-transplant is very high, and so it's a high-risk patients. Just remind you these things. So, is it still a problem to have acute rejections currently? So first of all, acute rejection is defined based on clinical grounds, but histological grounds for sure. We need a kidney biopsy, and it's classified through the Banff classification. So the T-cell mediated rejections are very frequent, about 10 to 20% of the kidney transplant patients. They are present because the immunosuppression is not sufficient enough to block the T helper cells, and they are easily diagnosed, easily treatable, manageable with steroid pulses, and in some cases by anti-thymocyte globulins if they are refractory to steroids. Conversely, the antibody-mediated rejections who are driven by anti-HLA antibodies that are directed against the HLA antigens of a transplant are less frequent, far less frequent if you have a good immunological workup pre-transplant, but when they occur, they might be very terrible for the outcome of a transplant. They can come over various periods of times, either within days post-transplant or later on. So I'm going to see that. So chronic rejection, the T-cell mediated rejection has been recognized in the new Banff classification. It's a rare event. It's mostly occurring in patients who are non-adherent to the medications, or for patients who are not well exposed to tacrolimus, so underexposure. But the most important one is the chronic active, or at least chronic antibody-mediated rejection. In most of the cases, it's active. And it's mediated either by detectable donor-specific alloantibodies against HLA antigens, or in some cases, you don't have any circulating detectable DSAs, but the kidney biopsy will demonstrate some evidence for chronic antibody-mediated rejection, even though they are not detectable in the periphery. And this has been addressed in the new Banff classification.